So today, the key consideration is just to, and I think we know this, but just to revisit the reporting of the different severity levels of COVID-19 infection, talk about some of the interventions, both that are established and then some of the still ongoing trials that we want to mention. And then just to report the basic approaches to monitoring and treating COVID if you do so in the facility. So next slide, please. Yeah, so this is kind of, the epidemiology. So a very high mortality rate within the nursing homes as opposed to less than 4% in the general community. Obviously, this is all bent towards the older adults, right? So there's a 20% mortality in individuals 80 or older, regardless of whether they're in a nursing facility or not. Next slide. And yeah, just not a badge of red badge of courage here whatsoever. We just are here in the Dakotas. We're at the top of the list there for deaths, regrettably. So meetings like this and getting a better understanding of infection control, I think would serve us all well. And this is just a reminder that we were, pretty much, in trouble right from the get-go. Next slide, please. Yeah, and the other thing is just to be mindful of the fact that these holidays, right? So we still are seeing this with the Easter holiday, that there are these surges that are occurring. Curiously, the post-Thanksgiving surge was, so in one sense, the post-Thanksgiving surge across the country was across the country. The post-Easter surge or spring break surge seems to be more spotty in a sense. There's 5 states that have that are accounting for over 50% of all the new cases, but they happen to be variants, right? And so that's our new dilemma, is that the variants tend to be a little bit more aggressive, and the idea is that a vaccinated person may have a reasonable response to them. We don't know quite yet how robust in the nursing home setting those vaccinated patients will respond to the variant. So the bottom line is keep the variants out as best we can. Next slide, please. Just want to mention that I do medical legal work, for nursing homes. A lot of times nursing homes, particularly in some other states, are sued more regularly than they are up here in the north, fortunately. So I do, as a geriatrician, some medical legal consulting, and there's just a whole rash of COVID-related lawsuits, and there's just this big controversy, that everybody's supposed to be in long-term care immune from that kind of legal action, but it turns out that probably not so much. But the important thing is that your 5-star rating doesn't really predict the spread of COVID. So, it's evenly spread according to the quality star rating. And the important point is that all the surveys in nursing homes is that the COVID spread was done largely through asymptomatic people, which is really, that's the tough one, is to try, and that's why we do the screening twice a week, when the positivity rate is so high. And really the bottom line there, the bottom point is that the nursing home outbreaks are proportional to the community expression of COVID. So when we see these, lulls and these rises, these are important considerations, for infectivity in the facility. Okay, next slide, please. So just want to mention this kind of weird thing going on with COVID infections. I don't know, there's been speculation that Jonathan Toews, the hockey player, got COVID and, got taken out. It's a rumor, but, post-COVID syndrome is preventing him from playing hockey. Who knows? I mean, it's possible. But remarkably, there's, issues about stroke in young people. At my clinic, we had 3 people admitted under the age of 40 who had strokes. They all recovered, but Just really, really amazing. I just want to mention that heart attacks occur after any viral infection in older adults. So this is not particularly new because influenza can do this in older adults, but it's particularly different in this case with younger people. We need to be mindful of secondary pneumonia, and that's where we measure procalcitonin in the blood to see if there's a secondary infection. Typically, these occur about 2 to 3 to 4 weeks after the viral infection. And sometimes you can also get a staph pericarditis, which is more rare, but again, predisposes individuals to bacterial infections. Maybe at some point we can talk about the long haul COVID. There's various data that are suggesting that people who have survived COVID, up to 25% of them have the long haul syndrome. And now there's a new study out of Northwestern University that indicates that 1 out of 4 have some neurologic issues, whether they are associated with mood disorders, anxiety primarily, but also other neurologic issues that are related to probably best compared to fibromyalgia. So again, it's probably one of the other arguments for getting vaccinated if staff have not been vaccinated is that whether the 1 in 4 chance of the long hauler syndrome is is an issue or not for them. Okay, next slide, please. So if you can, in the chat box, can you list what you consider your top reasons for preventing outbreaks in nursing homes? So we identified one of those was not being able to identify the asymptomatic carrier. I don't know if you had any other thoughts. If you can put in the chat box what your experience has been. I'm not sure, Kelly, with all the other nursing homes that you're working with, do you have any observations? We've got one here talking about mask fatigue, which I agree with. Yeah, residents not following the masks. I'm with that one. I'm counting how many patients in my clinic, which is a geriatric clinic, properly wear face masks, and I'm basically 100% of my patients are not wearing face masks properly.
Yeah, and I've seen a
These
lot
residents.
of vendors.
Go ahead, Kelly.
Yeah, no, I was just going to say I've heard of a lot of vendors or other essential people that have to come into the facility not following the facility protocols or policies.
Yes. Yeah. Good point. Yeah. Improper mask wearing.
Mm-hmm.
Good.
Yeah. Failure to report exposure is key too. People don't want to miss out on work, and unfortunately they lie. That's why we talk a lot about screening and making sure those policies are very clear. And if it's possible to have a screener there, because a lot of people will just, check the boxes that they know they can get by with and come in if it's just filling out the form.
Yeah, very good. So these are all points of concern. They can also be part of your root cause analysis for infection control. What we can do is compile your observations here and distribute that as kind of a list of barriers or challenges for infection control in general. So good.
Dr. Jurevich, I have a question just out of curiosity to ask the group. Did anybody see active cases coming back from those folks that had to go out to dialysis clinics? That's still, multiple people in a smaller area that had to go out, and you're there for hours at a time and residents wearing masks. Yeah, Megan said, yeah, I figured that was an opportunity because non-essential doctor's appointments were kind of on hold. But that's something you can't stop doing is dialysis.
Yeah, no, that's a good point. So the intervention there is to do testing when they come back from dialysis. So they're high targets, mm-hmm. But it looks like they're just from what everybody's reporting here that there are exposures and then some not so much. So good question. Can we have the next slide, please, Julie or Sarah? Yeah, so these are some of the additional concerns. One is the built environment, right? They've got double occupancy rooms, and so the spread from one resident to the other. The sharing of bathrooms could be another issue. The turnaround time for testing, that's gotten a little bit better here recently, but that certainly was the problem at the outset. And then the other part is what somebody already mentioned, is that we're dealing with staff resident interactions, maybe incomplete mask wearing or mask fatigue. I'm seeing that in my clinic, where folks at least are taking their masks off at their desks. They've all been vaccinated. We had 90%, actually 94% of all the providers got vaccinated in our clinic. So we're pretty good in that regard, but still there's that mask fatigue. And then some of these other points here that we talked about, resident staff and family members not adhering to proper mask wearing. Okay, so these are all problems that we need to recognize. So here's another one. Just indicate if you've had a positive antigen test from your screening here, and let's just say within the last month. Okay, good. Yeah, because the issue with the antigen screening is that you really have to have the on the ascending slope of infection, so you can be asymptomatic. Yeah, so that's good. So no positive antigen tests in the last month. Some have. So it looks like it's a screening tool, right? And you still have to follow up with the PCR assessments. All right. Well, thank you for those responses. Next slide, please. Yeah, here's the other question. I just want to get everybody's opinion again in the chat box regarding telehealth. Have you found it to be A, you can just list A, B, or C, as good as a face-to-face meeting, better, or less than a face-to-face meeting? So A, if it's suiting your needs, C, if not so good. All right, so a lot of C's there. Ooh, I'd love to hear about the B there. I hope that wasn't a typo. If it was better than face-to-face rounds there.
Would you all say that since there's so many C's, do you think that's just because the residents' resistance to participate in that kind of virtual setting, or was it more the physicians unfamiliar maybe with the telehealth program? I could just see some of that older group being a little more resistant to that.
Yeah. I mean, if somebody wants to unmute themselves and just comment about, what their experience was. Yeah. So Eric was talking about the uncertainty of the older adult. That's true for the memory impaired patient. Our doctors were misidentified, quite honestly, as family members. And so the Alzheimer's patients were looking at the screen and they thought, maybe that was their brother or sister or whatever. Yeah. So as Michelle's indicating there, yeah.
I can understand that, Jennifer. Everybody's stretched thin anyway, so taking the time to hold the iPads.
Yeah, we just as a side mention here about the iPads, we recently acquired a mobile robot, which is basically an iPad on wheels, and we're seeing if we can reduce the time of staff, from having to set up the iPad. But well, that's interesting. So so I think the consensus by far and away was that the telehealth is not working so good, and I guess some of the questions are whether there might be some opportunities to figure out some better ways to improve telehealth. So I just want to kind of throw that out there because there's an awful lot of effort to try to make telehealth work in some fashion. And that's particularly true with specialty care. In North Dakota, for example, we don't have a lot of geriatricians that can go from nursing home to nursing home. And one of the ideas there is that if we could develop a telehealth service like they have at Avera, for example, in Sioux Falls, they use telehealth quite frequently, for their nursing home encounters, and it seems to work pretty good. They get good results with that. So something to reflect on here. All right. Well, thank you for your responses to that. And the final comment from Jennifer: you need to have somebody oriented. Absolutely. Good. Next slide, please. So the big question is, can we prevent severe COVID disease? And the first and number one option for us is to try to reduce the viral exposure. There's this whole business of not only exposure to the virus, but to the the volume of the virus. That when we're exposed to small particles or few particles, that may not cause infection, but it's more of a critical level or critical mass of particles. So again, ventilation and mask wearing and are all key features there, as well as good hygiene. Vaccination is important. Of course, vaccination is not going to 100% prevent infection, so that's why it's number two there. I just want to mention these other issues about optimizing vitamin D levels, because there is some evidence that vitamin D is important for the immune system, particularly in the older adult, and really pushing the higher level. So if you take 1,000 units of vitamin D daily, usually you'll get above 40 nanograms per deciliter. So sometimes you have to nudge it a little bit more with 2,000 units for a short-term period. And then also optimizing vitamin C, that's best in the diet, but 250 milligrams twice a day is considered optimal. And then there's controversy about zinc supplementation, particularly if there's an outbreak, there could be consideration given to zinc 220 milligrams daily, but that's not something that you want to give somebody every day for the whole year. Next slide, please. So one of the recommendations is that if somebody is not on vitamin D, that during the pandemic, that you give them 50,000 units if it's not contraindicated, and then follow up with 1,000 units daily. Particularly people in nursing homes that don't get a lot of sunlight, with the quarantining and the isolation going on right now, there might be a lot of folks that are vitamin D deficient. The recommendation during infection is 500 to 1,000 milligrams twice daily. Regular supplementation would be 250 milligrams twice daily. And then those are the zinc recommendations there. Again, your medical director could help guide you on that. Next slide, please. I just want to mention beets. We grow a lot of beets in North Dakota. and there's a theoretical possibility that because beets help produce nitric oxide, that they may be protective. There are studies going on. They still have not reported out as to the efficacy, but they're doing nitric oxide inhalation, so that's is being looked at, for treating COVID. So I just wanted to mention that as a side. Again, this is not evidence-based. I'm not advocating it. I will suggest, though, for people that want natural remedies for blood pressure control, this middle point here is that regular use of beet juice does lower the blood pressure by at least 5 millimeters of mercury. So some people like to have non-pharmacologic interventions, and that's something that I always mention in my clinic. Next slide, please. All righty, so here we go with the severity. Now, one of the questions you need to ask yourselves, or we need to ask ourselves, if you went to a direct, a frontline staff member, a CNA, could they, if there was an auditor that came in and said, tell me what mild, moderate, and severe symptoms are. And so the key differentiation between mild and moderate in the nursing home setting is the subjective complaint of dyspnea or shortness of breath. All right, so the mild symptoms are fever, I will point out that the more aggressive the fever, so anything over 102 in older adults in a geriatric practice is not a good thing. Usually the milder temperatures are better, but the higher the temperature is a bad prognostic sign. So anybody over 102, the antennas should start wiggling there. But then again, the moderate COVID infection is somebody that has shortness of breath. The chest x-ray will show infiltrates. They'll have delirium. And I wanted to point out just at the bottom there that falls are associated with all 3 levels of infection. Okay, so falls at this point in time should be considered a symptom or a sign. Actually, it's not a symptom, it would be a sign of COVID, and those people should be tested.
And Dr. Juravich, if I can just add, you know, we've talked about rounding and such, and how you can add things to your checklist or your rounding list. This is a good opportunity to add something like this. And as you're rounding, you stop and talk to the nurses and ask them if they can give you the 5 symptoms that attribute to a severe case, if they can identify that.
Yeah, thank you for mentioning that, Kelly. That was actually a spot-on point that I was hoping to make here. And also, you know, as part of a intervention, you can make a little bit of, you can use this slide as a card and distribute that to your staff. So this is from the Institute for Healthcare Improvement, and you can use this, like I say, as a teaching tool. If you will, just, you know, to copy it and paste it and put it on a little 3x5 card, if you wish. Okay, next slide, please. So in the hospitals, there's a little bit of a different definition of COVID severity. So it's based upon oxygen or chest X-ray findings. So there's similarity, you know, that there's a positive chest X-ray with infiltrates that are the basis for moderate COVID in both the nursing home and in the hospital setting. But you can see there that the use of 4 or more liters of oxygen per minute is basically the cutoff for moderate COVID in the hospital. All right, next slide, please. So it's important to do a triage, right? So, I mean, a lot of this in terms of identifying hospitalization or do not hospitalization should be done quite honestly before somebody gets an infection. Should establish if this should happen, then what would be your wishes, either with the patient and or with their family. But certainly letting people know what those palliative care options are. You know, once you ask people, you know, what matters to them, like, you know, how important it is to get to the, you know, to be in the hospital, to do everything versus just make me comfortable. When that's applied across the board, there's some studies that show that 80% reductions in intensive care use, you know, as a result of that. So most importantly, you know, if an individual is in their 80s, they have multiple chronic conditions, their lifespan is maybe less than a year, that's an important discussion to have with them about the virtue or not of transfer to a hospital. Okay, next slide, please. So if we were to be treating COVID infections, these are some of the steps, you know, so this is a positively confirmed PCR test, presumably after an antigen test or not, you know, if you went directly to the PCR test. They should be in a COVID unit. we did the survey last week, right? Some people have their COVID units still, but they're not, you know, no patients, let's say, no residents, which is a good thing. And then importantly, that in that COVID unit, there should be at least daily, I really think, you know, 3 times a day, there should be vitals and oxygen taken, because in the older adult, their changes occur very quickly without always obvious evidence of it. And the reason is, and I'll make this point again, is that the oxygen drive in the older adult is much lower than younger people. And so they don't get that ventilatory push from hypoxemia. I can't tell you how many times I've get geriatric patients into my clinic, that are have a pulse oximetry of 90 to 92%, and they're sitting there like you would never know that they're, they're not tachypnic, they're not breathing rapidly. And it's not until you actually walk them that you start seeing their breathing rate going up. So that actually may be something that you might want to educate your staff on, that, when you get somebody transferred and getting them up and walking, if you start seeing them starting to breathe a little faster, that might be an opportunity to do a pulse oximetry and see if their oxygen goes down. But in any event, getting back to the COVID unit here, it's important that if somebody becomes anorexic, not taking food, they're unlikely to take oral fluids, and particularly in the demented patient, it's always the Dickens, trying to drink at least even a liter of water a day. So consider an IV. And another trick, by the way, is that if you can't get an IV in geriatric practice, you can do a subcutaneous infusion. So you can infuse up to a liter subcutaneously until you get somebody that can put in a proper IV. So that's just another geriatric trick, if you will, for hydration. We're going to talk a little bit about DVT prophylaxis because there is a increased thromboembolic association with COVID. And then also the opportunity to think about deprescription and what drugs should be on and not, during the COVID infection. And then also the monitoring with procalcitonin. Again, that's tracking the possibility of a secondary bacterial infection or pneumonia. And you probably would include blood cultures with that if there is a spike in the temperature or purulent sputum. Okay, next slide, please. Yeah, so in the non-critically ill COVID patients, so these are people that would be retained at the facility on the COVID unit. Just enoxaparin subcutaneously once a day, unless they're morbidly obese. So then you go to twice a day. You then also just considering what we call chronic kidney disease level 4, which is less than 30 mils per minute of creatinine. You'll see that on the basically the lab report. It's an estimated value. You would want to lower the enoxaparin, and then even further, you would use unfractionated heparin when somebody is on dialysis or in renal failure, overt renal failure. Okay, next slide, please. So the if the patient is on inhaled steroids, the recommendation is to stop that unless they have asthma or if they have the bronchospastic version of COPD. And I'll just mention another trick or whatever consideration in geriatric practice is to do what I call forced expiratory breathing. And so you have the patient, or resident, take a really deep breath and let it out as fast as they can. And sometimes you'll hear wheezing with that maneuver. So that's always important to do what we call forced expiratory ventilation. In terms of the others, trying to avoid NSAIDs. Some people are on Celebrex, or ibuprofen. You try to avoid those at all, if at all possible, and rely more upon Tylenol. And if they're on the NSAID for their arthritis, using topical 1% Voltaren would be preferred to the oral version. Okay, next slide, please. Yeah, so that first line there of identifying what matters. So really, during this pandemic, we should, as best we can, try to redefine the health goals, make sure everybody has their pulse. We did a home visit yesterday, our first home visit out in the Fargo area with our geriatrics program. And the main point of the meeting, believe it or not, was getting the pulse completed with the older adult that we were visiting. So the point being is that these need to be continuously revised, particularly with people who may have had COVID and may have some functional declines as a result of that. Remember that infections, and particularly older adults that go to the hospital, 85% of them come back from the hospital with a new functional impairment. So there's this steady decline that occurs as a result of acute hospitalization. And anytime somebody gets hospitalized, it should be a moment of asking what matters again and redefining what their preferences are. In terms of testing on the COVID unit, so again, these are confirmed individuals. You also want to test for influenza, although we've not had an influenza outbreak, so that's good news. But also to follow up at the unit with a chest X-ray, an EKG, again, because you can get silent myocardial infarction. And you can see all the other tests here that we normally order. So these would be equivalent to what you're doing in the hospital, and the provider, physician, nurse practitioner, or medical director should be aware of all these. Okay, next slide, please. Just want to mention, has anybody used the monoclonal Regeneron infusion in their facility? Just type yes in the chat box if you have. I think, at least in Fargo, there are some opportunities for nursing home-based infusions, but they also have the infusion center that we're using at Sanford. Okay, so if you have used it, just type yes. If not, then yeah, at the hospital. Thank you. Yeah, okay, interesting. Yeah, so most people are using a hospital or clinic. Yeah, all right, good to know. And just as a reminder, you've got that 10 days. So since the symptoms are positivity, you've got a 10-day window to use those antibodies. And there's some new interventions too, for the moderate condition, which, if you retain an older adult in moderate COVID, those are some of the hospital-based interventions that you can consider. And we'll talk about those shortly. Again, if it's getting to the point where the person has moderate COVID, then you're going to want to ask them if they really do want to be transferred to the hospital, get that confirmed. There should be a provider-to-provider handoff. So somebody, from the facility, whoever the physician or nurse practitioner is, should contact the hospital provider and give them an update. And it's really important, particularly in the demented patient, to describe what their baseline is. If somebody's always acting a little confused or they wander a lot, that's so helpful information, because if you get somebody that wanders, and they're being sent to the hospital, they're going to need some additional supervision, whether it be a sitter or equivalent. You generally try to avoid restraints, so you don't want to. Most hospitals should be a restraint-free environment. But again, that handoff is so important in terms of what the mental status is. Okay, next slide, please. So the point of this slide is that both with the survivors and with the decedents in nursing homes, it's an undulating course, and it's so unpredictable. And for the survivors, only 1 in 4 have this really mild, fatigability and tiredness. But most of them, 3/4 of them, have this vacillating symptoms. They've got good days and they've got bad days. And it's, over a course of, 7 to 10 days that this occurs, if not longer in some people. The people that are going to succumb to the disease have a steady, slowing, and worsening course. And about 1/3 of them will be looking pretty good. They actually look like they'll improve. And then the next day, you'll be doing a pronouncement. So again, it's a very, very uncertain situation with this disease, and that's why frequent monitoring is so important. Okay, next slide, please. So yeah, again, just to reinforce that we need constant assessments, really have a low threshold for additional testing, whether it be for, blood work or for bacterial infections that are superimposed on the virus. And again, I just want to reemphasize this point that the ventilatory drive from lowered oxygen or hypoxemia in the older adult is blunted by age. And so you're not going to see that reactionary, people will look and they'll say, oh, well, the nurse registered 18 breaths per minute, but the person had fulminant pneumonia. Well, yeah, that's not the nurse's, that's the nurse's observation. You can't impugn that or, suggest that they screwed up, because they didn't. The older adult is not getting that, rapid heartbeat and rapid respiratory rate because their sensors are not pushing the lungs or the heart to respond in that way. Now, mind you, if you get somebody that's got tachypnea with a respiratory rate of 24 or 22 or greater, that actually is probably puts that person in a category of moderate severity, and you need to reassess the oxygen, needs for that individual. Okay, so a little bit on that. We talked about some of the newer interventions. So these antibodies against IL-6 have been demonstrated to work and are used for moderate to severe disease. And again, if you retain a patient or a resident on your COVID unit with moderate to severe disease, you might want to talk to pharmacy about, this option for the IL-6 antagonists. I've not heard of anybody using that in long-term care, but quite honestly, if you got an IV, it should be an option. Nothing about nitric oxide gas as an antiviral treatment. So I just put that in there again, just to remind us all that people are looking at these alternative interventions going forward. Next slide, please. Yeah, so this just shows the mechanism of the antibody. We can skip this slide and just really show you that there's a 8 to 10% reduction in mortality. And these are ICU patients that are getting these new monoclonal antibodies to IL-6 receptors. So good news in that regard. Just want to summarize here that we know about the unique controls. We've listed those. We'll get that list out to you that you talked about in terms of the barriers to infection control. We still are waiting, in a sense, about the vaccine prevention, but so far so good. We've really had a very, very good impact on reducing COVID deaths in nursing homes across the country. It's important to readdress advanced care planning almost on a biannual basis now. I mean, it certainly should be done annually. And just to mention that I don't know where the V went in that last line there, but COVID-19 treatment strategies are still evolving as we would expect. And particularly with the new variants coming up now, the P1 and that B117 or whatever that one is from England. Okay, so I think we can move into our case study now. So can I hand this off to Kelly and Jean?
Yes, thank you. And just a note, you mentioned on the advanced care planning, I think that's really important to reevaluate everybody following or in response to this pandemic, because they may have different preferences now after they've seen what's happened to so many people. So I think it's important that you have those conversations again as a result or as a response to that. Okay, well, we'll go ahead and get started. Before I go to the next slide, I just want to tell you all that starting this week for the next, I think it's 6 weeks, I didn't look exactly, we're going to look at a case and then we're going to build on this case each week to create an entire performance improvement plan. So we'll go ahead and go to the next slide, please. So our case study is during weekly testing, it was determined that 2 residents and 1 staff in the facility tested positive for COVID-19. And the interdisciplinary team reviewed the cases to determine the source and put next steps in place in an attempt to prevent a future outbreak. So First, I want to kind of go through some questions, and I have a couple of options on each screen of a response to the question, but I'd like for you guys to add into chat anything that you may have in addition to what I have on the screen. On the next slide. So once you determine that there's an outbreak in your facility, what actions or what steps can be taken to evaluate that current outbreak? As you can see on the screen, I've listed some options. Obviously, whenever you have an outbreak, you want to quarantine or isolate those staff and residents. Look at your screening log that may assist you in determining where the source was, as well as to see if you have any gaps in that process. And then, of course, really determining the source. Are there any immediate steps that you guys have taken whenever there is an outbreak, just to share with the group, because there may be some folks who have some missing pieces?
I was going to ask Kelly, do I recall you telling the one of the cases that you encountered where somebody had a screening log and somebody dutifully reported that they had symptoms, but but they didn't verbalize it, and somebody didn't look at the log until the next day or something, right?
Yep, absolutely. And it was, I don't remember if I mentioned it to this group or a different group. It was because they had symptoms and they related, it was two individuals. One had symptoms, they related it to side effects from the flu shot, and the other had symptoms and attributed it to seasonal allergies. And both were recorded on the screening log, but it wasn't caught until too late, and they had infected, I believe it was like 17 patients. Janessa, who else may have come into close contact with those that tested positive? Yeah, absolutely. So you can start evaluating them and treating them as needed, or isolating, quarantining them. Most definitely. Yeah, anytime that you recognize an outbreak, definitely, if it's a staff member, who all have they been taken care of, and make sure that you're closely monitoring that. Definitely. Okay, we can go to the next slide. And what processes should you observe to rule out non-compliance? I think through this entire pandemic, we have talked about hand hygiene and PPE use. I think that is on the top of everybody's mind, but there are other areas that can be evaluated as well. I mean, look at your disinfecting process between patients. Look at not just PPE usage, but your PPE supply. Do you have enough, or are people reusing stuff because the order wasn't there? I was talking with a facility the other day, and we discussed, or maybe it was one of these calls, we were discussing PAR levels for your central supply. You know, for years we've set some kind of PAR level or order guide whenever we're wanting to order supplies. But now, in response to the pandemic, maybe we think about having more of this on hand should something happen or come up again where we didn't. I know when I was in the facility and we had somebody on isolation for, let's just say, C. diff, and it's like, oh, we only have 3 packages of gallons left. Let's make sure that we get it on our supply order, because they just weren't used as often as what they are now. So may have to reevaluate those PAR levels on some of that PPE to make sure that you have enough on hand. But I'm sure there's other options, and please, I welcome you to chat in if you have other processes that you could watch. Dr. Jurevich, do you have some?
Yeah, thanks for asking. I actually did, which was, and I wish we had Faye here, our infection control expert from the state of North Dakota. But we'll have to get back to folks. We can send out an email message for sure on this question, which I have, which are the N95 masks. You know, so there was the whole thing of the KN versions. You know, the masks that were coming from Asia were up to 60% of them were ineffective. Like they weren't working. And have you had any additional feedback on those particular types of masks, or?
No, I
yeah.
But I would say that your fit testing for those those masks too. I mean, what is that process? Who is doing it? Are they competent in doing that evaluation or that test? I think and who's your backup? I mean, if you only have, let's say, 2 people who can do the fit test or know what they're looking at, what happens if they're not there? And are they just putting it on and going? So I think that those are processes that we haven't had to really use historically in nursing homes. And so when you put them in place, you need to make sure you're testing the reliability of them once you've put them in place. And that goes back to those 5 attributes. I'm going to say it again. You'll hear it all the whole series. So anyway.
Yeah, good point. And I would just add to that, right, that they should be spot checks, right? You don't have to do the whole gamish, but in terms of audits, doing 5 or 6 at a time and figuring out, let's say if you're doing the fit test, that's the way you check.
Absolutely. Okay, and we'll go to the next slide. And then what quality improvement tool can you use to determine the source or the reason for the outbreak? And I go back to those five questions again. I think that when you're looking at those processes, you ask those 5 questions to 5 staff and determine if there's gaps in those processes. So if we talk about screening, are your employees able to tell you who does the screening? Where is it done? When is it done? How is it done? What do you need to do it? And if they're not clear on that, then you may be missing something there. For example, I gave about the screening log earlier and how it wasn't checked timely enough, and it ended up in an outbreak. So that could have been identified when you're talking to those staff too. And then also your root cause analysis. It's very important when you're looking at quality improvement that you're always doing a root cause analysis, because you can put systems in place 10 times over, but they will not be successful if you're not addressing the root cause of the issue, or I like to use the term opportunity for improvement. So it's very important that you really dig down and figure out what the underlying issue is so you can address it. And so today, actually, we were going to focus on root cause analysis, and I know we have limited time left, so I'll try to be as brief as possible. Many people, there are multiple tools out there you can use. Today, we're just going to look at a fishbone diagram as well as a 5 whys tool and see how we can start building out this performance improvement plan. Go to the next slide. So this is just an example of a root cause analysis fishbone diagram in response to the outbreak of a COVID outbreak from an asymptomatic vendor. And so what was determined during the interdisciplinary team reviewing the outbreak is that they had an asymptomatic vendor that came in and was unclear on the policy and wasn't wearing I believe it was their N95 mask correctly. And they didn't report their symptoms on the log, but it didn't get anywhere else. So let's just say it's an X-ray tech that came into the facility. They didn't have their mask on properly. It wasn't fit tested. They did have symptoms that were recorded on the screening log. And so during a root cause analysis, this is what was determined. In this particular case, this is just a sample case once again. But you use this tool by a group sitting in a room and everybody throwing out the ideas of how did this happen? How did we get to this end result? And trying to determine which processes may have gaps or opportunities for improvement in order to move forward. You can go to the next slide. And then this is the 5 whys tool. This is more of an interrogative process opposed to the fishbone diagram, but you can just continue to ask the question why. So screening indicated exposure that the vendor still entered. Why did that happen? Because the screening form they didn't report it to leadership or the appropriate person. The facility policy didn't indicate no entrance for exposure, but only for symptoms. Why is that? And then the vendor was required to wear N95 mask with full PPE when entering the facility, but it wasn't fit tested. So you continue to go through that why question to determine that bottom line. Okay, we can go to the next slide. And then, as I mentioned again, this slide pops up all the time. In order to find some of those items that you list on your fishbone diagram, or even through your 5 Whys tool, you can get it from interviews from staff. They are frontline, they see more than anyone else. And so they should be able to give you some feedback as you're doing your rounding. I know I mentioned earlier, when you're doing rounding, ask about those symptoms. It's a great opportunity. Maybe that is simply it. During your rounding, you're asking about those symptoms, and the screener, for instance, maybe a nurse, and the screener is unable to tell you what those symptoms are, but she let 3 folks come into the facility that were exhibiting those symptoms. So that would be an opportunity identified right there. Also, the other item I was going to note, Dr. Juravich had listed on one of the slides at the beginning some possible issues or areas that could be related to an outbreak. And I think you can use these too whenever you're doing a root cause analysis, because it may trigger for them, like, oh my gosh, I did see that happen, or I did observe this, or somebody reported this to me. And it could be going on in your facility, but use it kind of as a starting point, or a menu of items to choose from, so to speak. You don't want to make things up, but sometimes it just triggers those ideas for folks as you're going through a root cause analysis. And I believe that is our last slide. So I'll turn it back to you, Dr. Juravich.
Oh, thank you. So let me see if I can do this in a minute or less here. So next slide, please. So just in terms of management of COVID, importantly, reassess the advanced care planning. I recommend using, if you go to the website and Google ePrognosis, your providers can estimate remaining life expectancy, and that can help guide, what that particular resident's life expectancy may be, and that may help guide the advanced care planning. Remember that both staph symptoms as well as the older adult symptoms may be much more mild now with the vaccination. So again, GI distress, runny noses, all those would be fair game for testing. Next slide, please. We got those polls that you can fill out while we're going here. And then these are some of the points that we were talking about. The mainstay on the top here is just supplementation with vitamin C, D, and zinc should not hurt. Next slide. And pay attention in the COVID patient to their hydration status, frequent monitoring. And just to point out, if you do use proning techniques in your facility, that requires 3 hours twice daily. So we can go ahead and, and then the palliative care. There's a resource here about GeriPal. Again, you can Google that, and that could be some important options for you.